Thanks, Marta. That was a really fascinating case. And welcome right now to the round table. I have Jose and Marta here live with me today. And I'm just going to start with this idea and question really for both of you. Maybe Jose, I can start with you. I mean, when we're switching drugs, we're often switching them because of side effects or drug interactions. And I wonder whether or not now uh, we're doing less switching for drug interactions because we're starting people on drugs that have fewer drug interactions. And in fact, our choice of initial therapy is a little bit more based around drugs that have less interaction potential. I don't know what you think about that.
Yes, I agree with you, Anton. Our initial choices for starting antiretroviral treatment now include drugs with less potential for drug interactions, and we are start many patients on unboosted regimens, so we avoid many of these drug interactions. So the need for switching to drugs with less interactions later on is much lesser than years ago.
Okay, and Marta, what do you think about that? I think we're doing that in our practice too.
Absolutely. So yes, newer, more modern third agents are characterized by a lower potential for drug interactions. They're simpler to use from that point of view. But if you don't mind me answering with a question, because what I think we're starting to do is to actually actively switching people off from boosted agents. And without shame, maybe I should be embarrassed, but I'm saying that we had another case of Cushing, iatrogenic Cushing this week in our outpatient clinic. And I say without shame, and maybe I should, because I think, immodestly, that we're doing our absolute best to prevent the drug interactions. And then when we find someone with a resistant test, a baseline that was wild type, that still is on a boosted protease inhibitors and hasn't been switched, I eat my hands because, well, clearly, even if we tell general practitioners, we tell the patients, we spend a lot of time with them talking about interaction. This particular subject had intraarticular steroids injection from a private doctor and has Cushing, iatrogenic Cushing. So all of this, sorry, to ask, do you, Pepe, um, actively change people who there and then don't need to don't seem to need to change away from a PI, but because you worry about future interactions?
Thank you, Marta. Yes, I'm very proactive with this, and I always try to go to unboosted regimens, even when patients are not on current treatment. But if I envision that they must need anything, but for example, this is a good example because you don't envision that one of these patients is going to have a backache and is going to see a traumatologist and is going to receive corticosteroids. So we should be very proactive. Having said that, it's important. I always say the same message. When we go to unboosted regimens, we don't go completely away from drug interactions, of course. And we have to cover and we have to teach patients about other drug interactions with divalent cations or PPIs if we are going to use rilpivirine or whatever. So we move to less drug interactions, but we have to teach patients how to manage them.
Yeah, and I suppose the other issue that's really important now is the aging population and preempting them being given lots of drugs as they get older for their hypertension, diabetes, etc., which may impact. And Marta end up with a situation a little similar, where the GP gives some antihypertensive at a dose that with a booster would make them faint or collapse. So yeah, with the aging issue, that's always something we have to be mindful of. And I quite like the that drug interaction pie charts because it really does highlight how much we get a problem with boosters. So just to change the subject now, it's really a question, Marta, to you, is about counseling women of a childbearing age, and it's about the dolutegravir risk, because it appears to me that the risk is slightly higher than the ephedrins risk, say, or other drugs, non-dolutegravir risk. But probably if you take folic acid into account, the use of that, the risk is probably less than we actually see. But how do you address that with patients? Because I think that's, if you're going to switch them to that.
Absolutely. So it's a very good question, and I think it is a matter that has raised the confusion over the past few years. So everything started, as you well remember, Anton, in May 2018, when the first data from the TEPAMO study were presented at one of the WHO boards, and showed that women who conceived on dolutegravir had a higher chance to have a baby with a neural tubular defect. However, over the past 2 years, with the increase in denominator, meaning with the increase of number of women enrolled into the observational study, that was actually designed, correct me if I'm wrong, Anton, to look at malformation and teratogenicity of efavirenz in large populations in sub-Saharan Africa. So when more data became available, because more women conceiving on dolutegravir, following the rollout of dolutegravir as the preferred third agent in first-line antiretroviral treatment in the WHO guidelines, the number of NTDs that was measured went down, because, again, for this kind of rare situations or clinical scenarios or events, the denominator, the size of the denominator is really important. So now we see a lower prevalence of NTDs in women conceiving on dolutegravir. The study was run in Botswana. Interestingly, it's worth adding that no other observation, no other study showed an increased prevalence of NTDs in women conceiving on dolutegravir compared to other groups conceiving either on antiretroviral drugs or not having HIV. So all of this to say that led us to have discussions with women on dolutegravir that were considering conception. And at the beginning, we did call everybody in the clinic and tell them, this is the data, you have a choice, what would you like to do? Would you like to change or not? We are still having that conversation if we see a woman of childbearing potential on dolutegravir, but we do stress that it's not as frequent as previously thought, and that it was only one study out of many, I would add, that report that. So I don't think anybody has the answer, the scientific, clinical answer. Yes, you have to absolutely change dolutegravir or not. I think the fact that the woman is informed about it and makes an informed choice on whether to continue dolutegravir or switch is the most important factor of this discussion.
Yeah, I know, I agree with that. I mean, we have data on raltegravir, but not on bictegravir. And really, Jose, when we go to the injectables in and we start giving it to women of childbearing age, what are you going to say to them? Yeah, there you are, switch. Complications of switch.
Well, it's going to be a thing, no? I agree how Marta explained this issue, no? And if you get full information and it's an informed choice, the problem is that with Cabo we don't have any information yet about pregnancies with Cabo. So we will have to generate this information in order to make this choice.
Yeah, because it comes around to what you were saying, Marta, about trying to recruit women into trials early enough at the right stage so you can start generating this data. Because if long actings and cabotegravir rilpivirine is going to be with us very soon. If that is something that people want to choose, it's going to be very difficult to say to women of childbearing age, I'm sorry, we're going to exclude you, or you've got to use contraception all the time while you're on this drug.
Yeah, it's difficult. And it's also, you know, it's easier to manage the third trimester because you already know that a woman is pregnant.
Yeah.
You know what to do, but you don't know when conception happens. So it's quite difficult, and that's why I think the conversation is really important. And to underline what you said earlier, Anton, the folic acid story is also very important, because in Western countries, folic acid it's much easier to provide to women of childbearing potential.
Yeah, and so again, it comes back to what you've been saying, Marta, about talking, and to you, Jose, about talking to the women and making sure they're fully informed. And I think community's got a big role here too. Sorry, Jose.
No. I was going just to point that half of the pregnancies in our patients are not planified. So if we are very strict, so we cannot exclude all women childbearing potential because of this topic, because they are not going to planify their pregnancy. So.
Yeah. So there's some good questions coming in. One is with respect to DDIs, Metformin, where they've been reviewing their records on Metformin, and while they've been on DTG and even on the high dose, they haven't seen much toxicity. So although, I mean, we're told you could halve the dose of Metformin if you go on dolutegravir, some people seem to, according to this, seem to have done jolly well in spite of staying on higher doses. Any thoughts?
Yeah, so we have quite a bit of experience about it. So just very, very briefly, there is an interaction where dolutegravir inhibits the renal elimination of metformin in simple terms. So I think the most important thing here is to look at renal function. So if the renal function is decreased, metformin is already an agent that needs to be used with caution. So that's very important. And also the other, so with also older ages, extreme ages, renal function can be slowed down and metformin can be more toxic. So there's different factors to look at. We have quite a lot of experience of using metformin with dolutegravir, and we also have experience of using doses higher than 500 milligrams twice a day. So in people with normal renal function and metformin at 500 milligrams twice a day doses, I would say, you know, of course, monitor for side effects, but I don't think it's quite rare to see toxicity. Again, we have experience of doses higher than 500 milligrams twice a day, even 1 gram twice a day, and we haven't seen any kind of toxicity, and they did continue their dolutegravir. But it is in those circumstances that it is really important for monitor for toxicity and evaluate the need for dolutegravir. I mean, sometimes it is really needed because it's people who have a bit of resistance already, and dolutegravir has a high genetic barrier to resistance, and it's probably easier to keep them on dolutegravir, manage the interaction with metformin, monitor for toxicity, then switch them to a boosted PI, as we were saying earlier. So that's our experience.
And with you, Jose, your experience with high dose metformin and dolutegravir, have you seen any problems?
No, we don't have any in the clinic. We haven't seen any problem combining metformin with dolutegravir. But I agree that in the points that Marta said, that pay attention to the patient's age and to the renal function. And I would also add to the dose of dolutegravir, because the increase in metformin levels is dose dependent on, and if you are using BID dolutegravir, the increase is higher than if you are using dolutegravir QD. So I also would pay attention to that point.
Yeah, and all drug interactions aren't just one-on-one. They can be very complicated. Jose, there's a question about rifapentine as part of TB preventative therapy. And obviously, some people are using this daily, and some people are using it weekly. And it's about the interaction with dolutegravir and what advice we give people.
Well, I don't have any experience with rifampicin, and this topic has come out in some discussions whether it's going to be different if you are using rifampicin weekly, because then the inhibitory effect in transporters may be larger than the inducer effect in metabolizing enzymes. But there are no data. I don't know, Marta or you, Anton,
No,
if you have any knowledge about that. But I think it's all theoretical. And
I agree with you, Pepe. The data are very scarce. The problem is that there was a study that was designed and commenced in people without HIV, in HIV negative volunteers, but because of toxicity, mainly liver toxicity, in the first few volunteers that were enrolled, they had to stop the study. So they have PK data on 3-4 people. And the PK data show that dolutegravir is decreased by 50%, but it's not enough to draw conclusions on the interaction. So it is quite difficult to draw a conclusion. And it is one of those rare situations where actually we should do therapeutic drug monitoring, because you can start people and give them dolutegravir once a day or twice a day and measure the levels, and then clinically manage the individual. So really individualized therapy, and clinically manage the individual with the TDM until a study is available. I think there is a study running in people with HIV that are less likely to develop toxicity, that is looking at dolutegravir concentrations with rifampicin. So hopefully we will have the data, because although in certain areas of the world is not very relevant, in other areas of the world, this is a very important piece of information because of the use of rifampicin isoniazid in TB prevention.
Yeah, a lot of us in Europe can't get hold of rifampicin, so it's theoretical for us, but other parts of the world it is. There's two things to say. One, is really interesting that healthy volunteers, TB drugs and antiretrovirals seem to mean liver toxicity, and you give it to HIV patients, you don't see it. And the second thing is that it's less powerful of an inducer as rifampicin, and there's some data that rifampicin even once a day. I mean, dolutegravir once a day with rifampicin is enough from Botswana. So it's all very intriguing, the rifamycins and this, but there's nothing like good, hard data. And just a last quick question. What do you think the major issue is going to be in terms of drug interactions for the new injectable? Just a word or two. You know, you've got wild type virus, you switch to an injectable, and you're growing old. Marta, from you, anything that you want to say?
Moderate and strong, obviously, inducers.
Yeah,
but
okay.
We need to watch moderate inducers, chronic dexamethasone, rifabutin, modafinil, moderate tamoxifen. Moderate inducers will affect, I think, the injectable.
Pepe, anything from you?
No, nothing to add. I think the higher risk is going to be in patients taking inducers, moderate and strong inducers, anti-epileptic drugs, for example, is going to be very relevant.
Yeah, and those patients growing older are going to be taking more and more of those. So let's hope we can do some drug level monitoring on the people on injectables. Okay, well, look, thank you very much. It was a great conversation. I'd like to thank the audience for their questions as well. And I wish you both a very nice afternoon. And thank you very much for being on the program.
Thank you.
Thank you.